My name is Dr. Jennifer Vines. I'm the Deputy Health Officer here at Multnomah County Health Department. I do a lot of the medical leadership for our day-to-day work around communicable disease and sexually transmitted infections. And we're talking today about HIV, and just as background, Multnomah County and governmental public health has tracked HIV disease for decades. So labs, healthcare providers, and hospitals are required to notify us of new infections. And we have a very robust system of following up on those new infections, so finding people to make sure they know their status, linking them to care and other resources, and tracking down any partners who need to be notified and potentially tested for the virus themselves. For the last 5 years, HIV infections have been declining. Our toolkit has grown. Antiretroviral treatment for HIV is effective, and it basically makes people almost unable to transmit the virus to others when they're on good treatment. We also have another antiviral medicine that's called pre-exposure prophylaxis that someone who is at high risk can take every day to significantly lower their chances of acquiring the infection. And this is all along with years of encouraging condom use and supporting syringe exchange so that people are not spreading the infection by sharing needles. So that brings us to today and a very worrisome increase in HIV infections in Multnomah County. In the last 18 months, we've seen 42 new cases of HIV reported. I have to compare that to 25 total for the years 2016 and 2017, so that's 42 cases in the last 18 months. Half of those had recent negative tests suggesting that these are new infections, and a significant number mentioned either methamphetamine use or injection drug use. So these are cases among men and women. They are from all over the county, and a sizable proportion of them were actually diagnosed through emergency departments and hospitals, in addition to sort of the full spectrum of healthcare, private clinics, publicly funded clinics. So we're here today to emphasize the role of healthcare providers in helping us screen and find new infections so that we can help link those people to the care they need, lower their chances of spreading the virus, and better understand what's happening in our community. So we don't know if this is a short-term increase or a long-term trend, but again, there's work to be done here, and we have the tools to do it. So thank you again for coming today and for helping us get this important message out. So I will just also emphasize, in addition to getting healthcare providers to screen, of course, we are working with partners, which Kim Taves is going to talk more about, to getting to people that we believe to be at risk, which again are anybody who uses meth in any form and anybody who injects any type of drugs. We are looking to get those people screened at a place that will welcome them. So I'm going to turn it over to Kim Taves to talk more about preparing for what we hope will be an increased demand for screening.
Hi, my name is Kim Taves. I work with Multnomah County Public Health. I'm the Communicable Disease and STD Director. So I'm talking about what we're working on right now and what we'll be working on this summer to respond to the increase that we've seen in new HIV cases that report methamphetamine use or injection drug use. In addition to a clinician alert that we've sent out to the healthcare provider community, asking them to help us with HIV and syphilis screening, as well as Hep A vaccination for folks who use methamphetamine or folks who inject drugs, as well as their sex partners. The focus there is especially among emergency departments, who Jen mentioned, we want to acknowledge have been very helpful so far in screening folks at risk for HIV, and we'd like to continue to do that work, as well as addictions treatment partners, safety net clinics, corrections health. We're also asking other community partners to help spread the information to the clients that they work with day to day in terms of homeless outreach providers, other service providers, harm reduction providers, and help those folks link to testing. That may not be everyone's top priority when they're trying to get their basic needs met for food, for housing, getting to work, et cetera, but it is a long-term health issue that's really important, so we'll need to have folks help encourage people to test. Amongst our own staff, we have low-income, low-barrier testing, both at our Std Clinic as well as at our Harm Reduction Center. And we're ramping up our capacity to provide more testing to folks with no wait and a walk-in capacity so people don't have to make appointments. We've also started to do some testing in homeless camps, and we will continue to do that, as well as treatment for some STDs that are needed there. Our Std Clinic provides PrEP, which is the medication that Dr. Vines mentioned that can prevent HIV infection. And we've got folks on staff to help people who are uninsured or are low income or have a high deductible to get drug assistance program help to pay for that so that it can be affordable to people. It's very effective. Last thing our team does is we help notify partners, and our team also helps link people to care. There are a variety of HIV service providers, and we help coordinate that system of care for people because, as Dr. Vines said, if someone is on effective treatment for HIV disease, it's virtually impossible for them to transmit HIV to somebody else. So that is actually one of our most important prevention strategies, is to help people stay in care. So we not only have great, non-judgmental healthcare providers providing HIV care in our community, regardless of people's ability to pay, but there's housing support, addictions treatment support, and some of those other support services we need to help people maintain in care. Condoms have always been important. We distribute hundreds of thousands of free condoms, and we'll continue to do that. Sterile syringes, so that people don't share or reuse their syringes, is an important part of harm reduction, and we'll continue to provide and to fund others to provide those services. And then our role is as well in data collection, and so you'll be hearing about our partnership with the Oregon Health Authority. Both of us have epidemiology teams. We also have our partners with Clackamas and Washington County, who have their own service providers as well as epidemiology folks. Those are folks who collect data, analyze data to track patterns of disease and other health issues among populations so that we make sure that we're putting our resources in the right places, and we'll continue to work closely together.
My name is Tim Menza. I'm the medical director for the HIV, STD, and TB program at the Oregon Health Authority. So as you've heard, we at the Oregon Health Authority have launched in 2016 End HIV Oregon. End HIV Oregon is our plan to end new HIV infections in Oregon. It includes 3 pillars, and these 3 pillars you've actually heard about from Kim Taves and Dr. Vines. The first is testing. Everybody has an HIV status, and we want to increase the number of folks living in Oregon who know their HIV status. And then the next is prevention, and there are many prevention tools, one of which is pre-exposure prophylaxis, which you've heard about again, and a combination of 2 medications you can take daily to prevent HIV infection. Others include syringe exchange. And then finally, treatment. We know treatment saves lives. It prolongs lives, the lives of people living with HIV infection and those who are what are called virally suppressed. So when their viral load is undetectable, meaning that it cannot be detected by the laboratory tests we use to look for HIV, the genetic material of HIV, that means they cannot transmit HIV onto other people. So in that framework, the state is providing support for this response in Multnomah County. And so what we are doing right now is looking to prioritize people who inject drugs who are newly diagnosed with HIV infection for linkage to care and sustained viral suppression. We are looking to prioritize those who are living with HIV, who inject drugs or use methamphetamine, who are not virally suppressed, but may have been linked to care at some point, to get them back into care to make sure they are virally suppressed. We're facilitating the use of low-barrier testing technologies for integrated screening for HIV, syphilis, and other related infections. We are also working with the county to provide a mobile testing unit. We're funding syringe exchanges and syringe exchange programs throughout the county, and will continue to do so, and also making special needs funding available for the response to this increase in HIV cases. We've also been doing ongoing work at the state with partners at OHSU to increase screening for HIV, hepatitis C, and syphilis in their emergency department. And in addition, we're in talks to leverage peer-based programs to provide wraparound services for people who inject drugs when they're admitted to the ER or hospital with a complication of their injection drug use. Finally, we are providing expertise in HIV surveillance and epidemiology. and maintaining open lines of communication between our partners. And finally, we are also providing education and trainings to providers, both in the Tri-County area and throughout the state, on the preventive care for people who inject drugs. Thanks so much.
At this time, we're looking really carefully at our data to look at patterns. You mentioned camps. A little more than half of our folks who are in this set of people who have said that they do have a history of injection drug use. It's not all the HIV cases, but it's an increased portion of them, which is why we're concerned. About half of them are unstably housed or houseless. About half of them do have homes. So I want to be clear that this is not a homeless issue per se. We don't have information right now about how long folks have lived in the area. I can tell you that some of the folks are people who haven't been tested before, and so they may have been infected for quite some time. The worry to us, as Dr. Mensah mentioned, is that some of them have tested negative, and it seems like it's more recently that they became infected. And so what we're concerned about is recent local transmission. We historically in Oregon have had a low rate of HIV infection transmitted through injection drug use, because we've had legal access to purchasing syringes without a prescription. We have had syringes exempt from paraphernalia laws, and we have had really robustly funded syringe exchange programs for many years, innovative across the whole country, with our community partner Outside In as well being the first of those. So because of those things, we know that historically we have not had a lot of transmission. Transmission through syringes and sharing syringes scares us because it's the most effective way to transmit HIV, unfortunately. It's easier to transmit HIV, therefore, through sharing a syringe as compared to through sexual activity. So we are concerned that it could rapidly spread locally. There are folks who move up and down through the I-5 corridor from California to Oregon to Washington. It's not surprising to us that we're having increase at the same time that Seattle-King County is among very similar populations. So, there is transfer of disease, whatever disease it is, across state and national and county boundaries, which is why all of our partnership together and sharing of information is really important. In general, we have seen with HIV disease throughout the United States historically that there are certain communities and subpopulations of folks who have higher rates of disease than others. That's not as often about different sexual practices. Sometimes it's more related to poverty, lack of access to health care, other issues that we call social determinants, right? Things that don't give folks an equal playing field for protecting their own health and their own wellness. That's been true. However, no one's immune to HIV, and so we don't want to dilute the message, right, that HIV is transmitted from someone who has a virus moving through their blood in a way that they could transmit it to other folks having unprotected sex or sharing syringes. We have virtually no transmission from moms to babies because we have a really good system of care for testing women when they're pregnant and getting them treatment if they need it. So we've had a lot of success there. So there's the both and, where we're both particularly concerned about certain populations of folks right now, and we don't want folks to say, that's a different kind of person, not my kind of person. I don't have to be concerned as well. I don't want to be alarmist, but we do want folks to seek testing and care. The good news for us about HIV care is that the treatments have improved tremendously over the last few years. They have far fewer side effects than they used to, far fewer pills per day. They're affordable. We have a great system of care for helping people pay for treatment. And we've got good care providers who are very caring and don't judge people who are living with HIV. So the treatment can help people live long, high-quality lives with good health for a long time, as well as not infect other folks. People sometimes are not aware that our treatment has changed a lot. They think it's the old-fashioned treatment we had that didn't always work, that caused lots of side effects, and it's different now. So I would urge folks to go ahead and test and not be afraid of that, and that there are resources for them if they do find out that they have an HIV infection. We have not had a decrease in syringe services. In fact, with the increase that we've had locally in methamphetamine use and the increase that we've had locally in heroin use, we've ramped up our services to meet the demand from folks for clean syringes, for other equipment, for referrals to care. So we have a pretty robust harm reduction services. Outside In is our funded partner. There are other folks locally providing those services as well. and we haven't had a decrease. It's an important time to focus on that, but also to focus on continuing what we do that works, but to focus on new and different partnerships and new and different things we haven't tried yet, both together. Yeah.
Overall, it's been a long time. And in general, HIV cases, both nationally, statewide, and locally, have been on the decline, with sort of a plateau in the last sort of 3 to 5 years. And so this level of this number of cases in this amount of time is different. So it's a bit more rapid. And while 42 cases doesn't sound like a lot, it is for HIV. It is for HIV infection, especially in the context of similar situations, like Kim had mentioned, in Seattle and King County, but there's also in Cincinnati, in West Virginia, and in Massachusetts have experienced similar, in addition to Scott County, Indiana, have experienced similar increases, some varying in magnitude, of HIV among people who inject drugs. And I think the thing that's also important to know is that this also comes with things like hepatitis C and syphilis. So we've been seeing increases statewide in the proportion of new syphilis cases who are reporting injection drug use, particularly methamphetamine. And we are also seeing an increase in the number of hepatitis C infections reported among people under 30. And the reason why we look at that particular age range is because we think that they've been recently infected, number one, and more often than not infected via injection drug use. So this is coming as a combination of things that almost have sort of predated the increase in HIV, but because the risks and vulnerabilities are similar, I think we're seeing the end result, which is HIV infection.
So if I could shift gears, again, our main message today that we hope you'll carry, and thank you for your interest in, is this increase in HIV and the call to healthcare providers and to those at risk to get tested and to offer testing. We couldn't ignore the opportunity in raising this concern about HIV. We couldn't ignore the opportunity to highlight some other diseases that are also either new or different, and that also have overlapping risk groups with those who should be offered HIV testing. So syphilis is a sexually transmitted disease. It's curable with antibiotics. It has been on a sharp rise in our county for about a decade, and it tends to be spread among men who have sex with other men, but it can also spread to women, and unfortunately pregnant women who get syphilis and don't get treatment can actually transmit it to their babies, and that's called congenital syphilis. So we've seen an equally, I guess I can't say, an equally concerning rise in female syphilis cases and in congenital cases, which the numbers are actually low, but it is, again, it's a preventable, curable disease through screening and effective treatment. Our communicable disease program is tracking cases of Shigella. This is a slightly different disease. It's a diarrheal disease. It's passed by getting particles of feces in your mouth, either through, people typically think of unwashed hands, but it can also happen through sexual activity. And we think that in our county, half to 2/3 of Shigella cases are most likely from sexual activity, and we've seen small clusters of illness among men who have sex with men. Cases are on the rise. Drug resistance is also a problem in this disease, so these are new things for our healthcare community to know, again, with overlapping risk factors that tend to be meth use, injection drug use, unstable housing, and men who have sex with men. And in no way do I want to stigmatize any of those groups. They all deserve our compassion and the highest quality care. Finally, we don't have any hepatitis A cases. We have not seen an increase in hepatitis A, but it is very much in the news as other jurisdictions, cities, counties struggle with outbreaks, again, in similar risk groups. So finally, we added a note to clinicians and highlighted the opportunity for Hep A vaccine, again, to those who need it, in the hopes of actually preventing disease in addition to testing and responding to the others. Again, I think unfortunately, these are overlapping risk groups where there's a lot of stigma and there may not be easy access to care, nor may health be an individual's particular priority on a given day if they're struggling just with housing. So again, these are not mutually exclusive groups. They are heavily stigmatized, so I would urge you to treat them with compassion in your reporting, but they are the focus of our attention at this point, in addition to other routine screening recommendations that are easily available to healthcare providers online.
I think there's a lot of different reasons for certain drugs to be waxing and waning in popularity or in accessibility. Some of that is the whole drug trade and business infrastructure of drugs is far beyond my capacity to address, but I know that there's been shifting in patterns of low-cost methamphetamine and heroin. We know that we worked very hard as public health system with our healthcare partners to try to address the increase in heroin when a significant part of that was from folks who originally became addicted to pain pills and then switched over to heroin. And when they switched over to injecting heroin, which is cheaper to buy on the street, then you have this whole host of infectious diseases that comes to bear as well. There's been some changes in drug use patterns where folks used to use methamphetamine or heroin, but not both, and we've seen an increase in the last couple of years of mixing of drugs, and so that means mixing of social groups, which means mixing of sexual networks. And I do think that sometimes when folks are houseless and they need to stay up all night to protect their own safety on the street, sometimes they start using methamphetamine just as a way to stay awake and deal with their own personal safety. There are other folks who end up houseless because of the drug addiction driving that. So those two are intertwined, although they're not mutually inclusive of each other. Those are some of the different dynamics. You know, we can look farther upstream at childhood trauma actually predisposing people to addiction in general, whether it's alcohol or drugs. So it's just as important for us in public health to be looking long-term at maternal child health, right? Stabilizing families, not disrupting families, as really important to have those people develop in the early years with the resilience they need and not be impacted by trauma later on. So we could go broad and wide with public health in terms of our understanding of some of these contexts, but thank you for the question. So you may be aware that the county budget overall, in terms of county general fund, and again, I'm in public health, I'm not speaking for the whole county and the budget here, but that we did across the board have some funding reductions in county general fund. Areas that aren't as much grants funded and are more reliant on county general fund sometimes were more impacted. So we did have some concern this spring about reductions in harm reduction funding. And through the budget process, which is a public process where there's community input, the commissioners together figure out a budget. Some funding that was going to be cut from harm reduction was added back to our program. Some of that has a one-year only stipulation on it. So our goal throughout this year is to not only be responding to this public health emergency right now, but also to be looking at new and different partnerships and structures for revenue in terms of sustaining the services that we need, even if we do have a decrease next year as well in county general fund.
You know, and the other thing from the state perspective is that we've also tried to create a program called Early Intervention and Outreach Services, where we've been infusing some money into the Tri-County area to get people newly diagnosed with HIV linked into care and virally suppressed, and also make sure that people who are diagnosed with gonorrhea or chlamydia or syphilis are tested for HIV, and if they're HIV negative, get them onto PrEP, and if HIV positive, again, get them into care so they can be virally suppressed with the effective treatments that we have available.